activities that he's been involved in that include his having been a vice minister, also a director general in the Ministry of Health, always dealing with issues of financing, always dealing with issues of the organization of the healthcare system, and with, I would say, from the very first time we met him, a deep commitment that healthcare should be available to everyone and that it should be affordable for everyone, and to actually take over a healthcare system, the basic financial structure of a nation of 280 million people now, something like that, and to have finally achieved just in the last several years, 96% of people are financed by that system. I'm sure he'll tell us that story. And of course, why we're very excited here to have him talk and visit us here is to tell us the story of how the kinds of obstacles he's faced, how he's overcome those obstacles, to what extent, what the real challenges are in an ongoing way. We've been discussing very practical issues around different aspects of healthcare, and the sort of politics of different of how much support to give for different kinds of conditions. And then I know in addition to that, Gufran has been very interested in moving this whole system more and more into a digital system, so that it functions from people's cell phones, it functions in a way that really incorporates all of current technologies. Gufran has lectured widely in the United States and internationally. Harvard is one of many places that he has visited and lectured. He has also been an advisor in WHO, an advisor in a number of international bodies, and particularly those who are committed to carrying out a kind of mandate for making healthcare services available and affordable on a global basis. And so it's with really great excitement and great pride that we're delighted to welcome Prof. Gufran to join us today. So thank you.
I think I will be standing here, just over there a little bit, of the shining light. Oh, here? Oh, yeah. Here it's okay. Okay, first of all, I would like to thank for the invitation of Byron and also Prof. Marijo, who already, for a long time we have been together. And even that time, both of you are very young, very, energetic. The spirit for not only in the psychiatric and psychological problems across Indonesia, but also, if Prof. Marijo remember, we gave lecture together in the postgraduate program about the, managed care or structural organization of healthcare. Okay, so first of all, if it is possible, actually, I would like to say, happy birthday and God bless you, or both of you. Of course, Marijo is the last one, because when it was in Jogja, Prof. Byron was also his birthday. Can we give something? Just, yeah. Yeah. So, just this, I know. So you use the batik.
Oh, thank you.
And we have also little bit, from BPJS. From BPJS, is there any? Okay.
Yes.
Yes.
Byron? Yes.
Byron, from BPJS.
Yes.
Yeah.
Okay.
before the lecture started. So that is BPJS Kesehatan. So when you would like to talk, that is about. Thank you.
Okay, thank you.
Okay, thank you very much. Oh, yeah. Then we can start now. Okay. The title is Insight from Indonesia, Achieving Universal Coverage with an Integrated Single Scheme in 10 years. You know, as you mentioned, might be number 3 or number 2 in the world, but in fact, for the comprehensive, like in India, of course, the population covered is big also, might be 300 million people.
Right.
But the problem is the coverage is limitation, not like in Indonesia, very comprehensive. So therefore,
In China.
oh, China, yes, but the China little bit fragmented because the rural and urban is different type of system. But of course, the population is huge, like in Indonesia. But as you know that number 1 population is actually China, but now overtaken by India. Yeah, already more similar, or maybe more in India now. And then US, and number 4 is Indonesia. So Indonesia is now the 4th most populous country in the world. And now we can, you know, previously, next slide, please. Next slide. Yeah. So about the universal coverage, and we are in the BPJS has duties and objective of BPJS Kesehatan to achieve universal coverage. And in this year, actually, we have been targeted to achieve 98% of the members covered by BPJS. But our position now is more than 96% of the population. Yeah, I know in US, but I do not mention it. Okay, then the aim is to increase the access of certain quality of healthcare with protection and efficiency, of course, the equity. If you remember in Jogja, there was a book entitled For the Poor, It is Forbidden to Fall Sick. And now I change. If you are poor, if you got sick, then it is forbidden to pay. If you are a member of BPJS. So the important thing should be the member of BPJS, the beneficiaries. And then what is universal coverage? Of course, according to WHO, there are 3 dimensions. How much is the population coverage? Then how high the benefit package? How wide? And then the out-of-pocket payment. So how much is the out-of-pocket payment? So basically, increase the access, accessibility, availability, acceptability, then increase the protection. There are no financial burden outside the entitled policy, including the long-term course of psychiatric patient actually should not be additional cost. Actually, the BPJS policy. But as I mentioned, sometimes because prospective payment, then the hospital trying to innovate new type of, increasing input of the tariff. So they make limitation, just 2 weeks, for example. Then quality, previously, because BPJS has seen it was, incepted, always has debt. And also we owe to the hospital, to the bank. So the hospital, especially doctors, our colleague, treated sometimes discriminated if the people are member of the BPJS. Then therefore, for the quality, we say should not, no discrimination. So this is not here, no discrimination. Efficiency, cost-effective medicine and health medical devices. Equity, whether it is related to the place, whether in Jakarta or outside Jakarta, but of course it is not easy. Then gender, age, and socio-economic status. Then this is the universal coverage. And this all supported by digital technology. So we are, as you mentioned, we are trying to use the industrial revolution number 4 or 5.0 to increase the digital transformation, even artificial intelligence to detect the fraud, hospital who are committed fraud. Next slide, please. So, not yet. Yeah. The problem in Indonesia, now we are having epidemiologic transition. And the elderly increased now more than 10%, around 11% of our whole population are elderly, more than 65 years. Of course, the cost is increasing because utilization is increased. And the coverage now already 96, more than 96, and every day it increased. And Pak David, here, this guy, who are responsible person as the director of membership. And the good thing, he is the former director of Telkom, one of the director of telecommunication. So we have to be, digital transformation, and he also supported. And Pak Mahlil here, he is the director of the research and development, planning and development, including research. So now we have a journal and we are doing research. And I will talk later. Next slide, please. So here, as we mentioned about WHO framework for health financing, where revenue, rising, pooling, and purchasing, and the benefits, then how to make equity resources distribution. Of course, it is not easy. Efficiency, transparent, and accountability. So our final coverage goal is that utilization relative to needs will be increased and covered. Then financial protection, equity and finance. So those who are rich should pay more, but sometimes not like that sometimes. And the quality. For the quality, we have quality transformation. Of course, there are many theory of increasing quality, like Donabedian concept and Edward Deming, where there should not be error, things on many things. But we have simplified it to be only 3 indicators. First, must be easier to go to health facilities, easier to have access. Then, number 2 is faster. Should be faster because before we inaugurated, many complaint from our members and just WhatsApp me. So because they said, because we are the member of BPJS, we have to wait 6 hours to get health services. Then I said, please, should not be confused because we are not yet inaugurated. You already protested us. So just wait. And then we develop queuing system. So now approximately 2.5 hours or 2 hours. Even now, they can queuing from home, from coffee shop, or from many places. And the last one is non-discrimination, or we call it equitable services. So that is very important because our members always be discriminated long time ago, not long time ago, 3 years or 4 years ago. Next slide. So here, the Indonesian islands, 17,000 islands. So we already achieved 96.36, and I think now it's more. David, I think you can add information, maybe more than 36%. Next slide, please. So when we read the Lancet, Germany, to get 85 population need 127 years. Belgium, 118 years. The fastest is South Korea, 12 years, 97.2%. And like Luxembourg, only less than 1 million people, but need 72 years. In Indonesia, we need only 10 years to achieve more than 96% with 268 million population, or maybe more now. Next slide, please. So here, so like in US, like managed care, but HMO. So we cover benefit package from health promotion, disease prevention, with screening, and then curative care, rehabilitation care, but they have to go to the primary health care first before refer to the higher level of care, secondary care, tertiary care. But if they have chronic diseases and it is controlled, should be referral program, and they can get many facilities on that. Next slide, please. So now we already contacted with more than 3,112 hospitals and 23,000 more primary health care and clinics, and 64% of them are private. Previously, they are reluctant to work together to collaborate with BPJS Kesehatan, but now they are in line. They want to be contacted by BPJS.
How did you do that?
That is good questions, but I'm not sure whether we have to answer now or after. Okay, of course that we now, why we are interested by them, why they are interested. First, we increase the tariff together with Ministry of Health. The first time in the history of BPJS Kesehatan, capitation is increased, never done before. Even the tariff in BPJS Kesehatan in hospital, we increase around 21% total. So previously we owe hospital, so we pay and pay to the hospital, and there is no debt, no owe. Not only that, we increase the tariff, but we also make guideline to them how actually you should increase the quality of care. Of course, for psychiatric, then we can discuss later. It is many problem actually still there, but the improvement is really, we can feel it. And satisfaction level increasing, huge number, now more than 90% or almost 90%. Previously is around 80% or more than 80%, done by independent body. Then not only that, I think the question is that we have many approach to the healthcare providers, because in South Korea now, healthcare providers is, struggling, even in UK, but thank to God, not in Indonesia. We will have a problem. But we have many approach. I will talk it later. Next slide, please. So that is the spending. Can he spending? So the spending now, I think 2023 always increasing. 23 is 158. That is like how many billion US dollar? Yeah. Yeah, 10 billion US dollar. Getting higher and higher. And this 2024, we committed our planning budget, we have to spend 176. So increase around 20 trillion rupiah. Okay. And actually we would like to strengthen primary health care. But again, the hospital is consume more than the primary health care. So around 87%. Next slide, please. So that is the drop. Next slide, please. So always increasing. That is also drop where not only in hospital, but also we, give the medicine for the chronic diseases, which is refers back from hospital to primary health care. Next slide, please. So that is the health technology assessment. If there is new drug or new devices, new procedure actually should go to the health technology assessment first. If it is proved that the new medicine cost effective, then should be paid by BPJS Kesehatan. Include in the national formulary first, then BPJS have to pay. Next slide, please. This is the process. So now, actually, as Prof. Byron mentioned about the political situation, collaboration, there are many stakeholders. If I can say, actually, in BPJS Kesehatan is the miniature of the government, because we're dealing with not only with the president also, we are directly under president. Then minister and agency, there are many ministers and agencies related to us. DJSN, National Social Security Board. Then OJK, that is the Financial Service Authority. Then BPKP and local government. And parliament always ask us, and we always be asked by parliament why you do like this, why like this, so on and so forth. So now we connected through 4 groups. First group, healthcare providers. We make connection with many new application with the bank. Yeah, many bank. So that is making us easier to collect the money. Previously, the collection rate never 65%, but now it's more than 95% collection rate. So with the members, too many things with the members, and also with the institution, ministries, local government, academician. We give connection and many things to do. Even with the, for example, dashboard. So the local government will understood and will know how many of them utilize, how many of them are members of BPJS Kesehatan. Whether they have already paid or not yet, they will know it. Of course, our approach like Industrial Revolution 4.0, 5.0, including digital transformation, mindset shifting among stakeholders, it is not easy, very difficult. Innovation in various aspects. So we, like in the university, we did many innovation and we developed innovation park in BPJS Kesehatan. Next slide. Yeah, so that is what I'm talking. For example, for membership. Now, not only digital canal services with Cika, Vika, Edabu, that is mobile JKN, and we call it SIPP, our rating. So the customers, the beneficiaries, after receiving services, they can give star. 1 star, 2 star, 3 star, up to 5 star. It is really very good to 5 star. And if 1 star, for example, that the nurses is not quite good, something like that, 1 star. And we can capture all this behavior of hospitals and primary healthcare across the country, 1,000. Not only the institution hospital, but also the doctors. We know that this doctor actually a day, how many operations they are doing. We know it. And not all hospitals and doctors know that we know them. Okay, queuing system, financial channel payment, For channel payment, now we have more than 950,000 channel of payment, like OVO, GoPay, Indomaret. For me to mention 10 is difficult, but we have 100,000 channel of payment. Okay. Supply chain financing, upfront claim payment, yes. Queuing system, teleconsultation. Previously, BPJS is only those who are sick, but now for those who are healthy, they can consult also. Here. Digital claim, analytical dashboard, as I mentioned, dashboard for local government, data sample for university, academia. So if doing research on, psychiatric, depression, who committed suicide, things like that. Okay, next slide. Yeah, this is our data set. We have many data set, and also for the data sample, data publication. Previously, there is very difficult BPJS to access the data, but now we open. But of course, gradually. So those who are postgraduate student, usually the problem is they have no problem. That is the problem. They do not have problem. So if you do not have problem and would like to find problem, please go to BPJS. Too many problems over there. You can find it easily. Otherwise, I can give you problems. Next slide. So now, more than 57 million data available, sample. So 82 million data in the year 2023, and we release the data so they can get the data, can access, but of course with special permission, because we would like to know whether after analyze the data, actually use the data to fire back us or to what, or to sometimes like that. Okay, next slide. So we have the command center 24 hours a day and 7 days a week. Always there is guard and people or person or staff who already monitor if there is a hacker or any type of abnormal things. Next slide. It is very funny. Many people are seeing this, but not yet the Minister of Health. Then we invited them to see. So then we should have you also, but we have just several days ago. Then he was interviewed. So he knows. Next slide. Yeah. So many countries now just visited BPJS Kesehatan. It's never happened before. So there are just many people are surprised that BPJS is already in that level of the digital transformation. Next slide. Yeah, that is what they say about BPJS. Next slide. For example, from the World Bank.
I think Indonesia's experience with JKN has not only been aspirational, but it's also been inspirational to a lot of countries which come from the same context, lower middle income countries that are aiming to achieve universal health coverage.
And then also coming to see the command center. I found the command center also something that is remarkable. I mean, that it helps you to get a feel of what is happening on the ground, and then how it is being used also to drive enrollment and all. I think
It is from Ghana.
I'm highly impressed. Yeah.
I congratulate everyone who's worked on BPJS. It's amazing to see the level of coverage across the country and to see the attention to equity and meeting the needs of the population.
The integration between levels of the health system and from providers to BPJS is something that's really stood out. So the way that the technology has been used and information is shared to provide better care for the population is something that's been really impressive, and I'm excited to learn more about it.
So I was very impressed by how efficient the leadership, how efficient the management of everything was.
BPJS keren.
So BPJS keren meaning BPJS school, something like that. Okay, next slide. Next slide. So as I mentioned that we now develop what we call it the medical record in the hand of the patient. So patient in Surabaya, for example, can go to Jakarta, then doctor in Jakarta will know what is happening, what, which health facilities the patient visited before 1 year, and then diagnosis and treatment, and also allergic, not only with the pollutant, but also with allergic agent, so will be recorded. So this is the iCare JKN, and yeah, we already developed this. You can imagine in US, for example, of course, in Harvard and maybe Mayo Clinic or in University of Washington, they do it, but not in the level of the whole one system like in Indonesia, because the system in Indonesia, the good thing is integrated in one scheme, previously more than 300 schemes. When we were together at that time, we gave lecture more, we have many Jamkesda also. Jamkesda is local government initiative schemes. And I was the one who gave the name Jamkesda. Then we do not use anymore. Although it's still there, some still there. Okay, next slide, please. So promotion prevention. This the business model of BPJS Kesehatan Protection System. So there are many things. Then I try to wrap up to be one slide. So the single scheme, BPJS Kesehatan, 96% coverage or more, always deficit and now is positive. Then down payment. So before we make, verification, then we already paid to the hospitals or clinics and depend on the performance. If performance is better, then we can give maximum 60%. Not only that, increase the tariff satisfaction. And this is the good thing, like in the WHO measurement, out of pocket payment. From in the year 2014, 49, almost 50%, now reducing into 25%. Not many countries like this, because sometimes, there is comfort, but not reducing out-of-pocket payment. Although still, in some cases, especially psychiatric, for the long term, they're still using out-of-pocket in addition of the comfort of the benefit package. Next slide, please. Not yet. So our members, actually, the employer and employee first register, that we provide information on the rights and obligation, this benefit services. Then for the contribution, those who are not have wages, they have to pay $3, $6, and $10 approximately. Then for those who have wages, the employees pay 1%, employer 4%. Then subsidized premium for those who are entitled and for the poor. So then we make quality transformation easier, faster, non-discrimination. And the way to pay the primary health care, we use capitation-based performance and some non-capitation. For example, Ministry of Health now by bought many ultrasonography, USG, to examine the pregnant woman, whether there is something happening or not, then we pay. And the antenatal care, we increasing the number. Previously only 4 times, now 6 times. And so on and so forth based on the performance. Then for the hospitals, we pay using INA-CBGs. First time it was developed in Yale University, the DRG, and non-DRG. We have medical advisory board and quality cost control team and also anti-fraud system. So again, BPJS is a non-for-profit legal entity and it is directly under President. Next slide, please. So because of our many innovation, then the ISA is International Social Security Association.
Yes, and now the winner can be announced. So I would like once again to congratulate all member institutions who took part in the competition. It was impressive to see the range and scope of the submissions. The one award we have not yet announced is, of course, the overall winner. So, from 108 entries in the jury had to select one that was outstanding and deserved to be awarded as the winner of the competition. So it is my great pleasure to announce the winner of the ISA Good Practice Award for Asia and the Pacific for 2021. It is the Social Security Administrating Body for Health, BPJS Kesehatan, Indonesia, for its National Health Security Program.
We thank to God because now many people are committed, our staff committed to work better. And when you calculate using FTA, full-time equivalent, when I entered, time FTA is 1.2, meaning 1% work more than 20%. Then now, and then we increase the commitment and workload then to be 1.5. Now it's 1.8. So 1% almost working as 2 persons, but the salary is 1. Okay, next slide, please. Next slide. So the problem is that is if I can conclude or before we have discussion. First, that BPJS Kesehatan achieves universal coverage with an integrated single scheme in 10 years, reducing out-of-pocket payment from almost 50% to 25%. With increasing access, quality, efficiency, and protection for the poor, although there are still many problems, but the improvement is there. BPJS Kesehatan has successfully improved financial status. Usually we always deficit, and not only Minister of Finance is confused, but also the President do not like it because always problem. But now they are very happy. Not only Minister of Finance, but also the President are happy. Then, of course, we pay debt of the hospital claim, giving cash in advance together with Minister of the increased tariff, also increasing satisfaction of the beneficiaries. Achievement can be accelerated by optimizing digital transformation, many things, online queuing system, iCare, JKN, saran, and channel of payment, anti-fraud system, many things. BPJS now is paying attention on promotion and prevention, including screening. So previously only 6 screenings, so we now gradually increase to 14 screening. And to be more cost effective, we can use screening only by using a mobile JKN, answering around 47 questions. Then we can classify and give feedback to the beneficiaries whether they are prone to have certain type of diseases or not, something like that, and rehabilitation. And sometimes, because the hospital, to make more efficient, committed to fraud, but they, connect with the content creator, the young people who have new profession to make content creator. If the problem is the content creator, sometimes then they don't know if the content is wrong. But the problem is the content is wrong, but it's already viral. And many people know about this. For example, one happened in the hospital in East Java, when we actually not cut, but do not extend our collaboration. Then this hospital are angry and, report to the Minister of Health, to legislative body, to many things, and then maybe connected to the content creator. And the content creator said that my father will die because BPJS Kesehatan stopped collaboration only in one, not in the discussion, but with BPJS authorities, so one side only, something like that. Therefore, we then explain to the public, including to the hospital and the content creator, how to do that, because we have no enough operational cost. Then we create a song, especially for the young, because they are always content creator. So this is, for example, next slide, viral content. So we create a song.
Sosmed is great for communication.
Sosmed is great for communication. Magazine, newspaper, TV are there.
Getting stronger during election. Sure you know about this connection. BPJS has been successful. Many issues social media, spreading out by YouTube and many others. Another message cause my words are scammer drama, such as a rose. ashamed of mistakes.
The clear wrong content that was so viral. But unfortunately, the sound is also quite good.
Don't really know.
The content they don't know.
Everywhere as a
They seem to
show.
ever everywhere.
After they're being told
After they
by
are being told that it is something like this, you are
they
wrong.
realize the contents of fate. Tragically wrong content goes viral.
The problem for the folks.
Corrected
Corrective
content
content
is
is ignored.
oh, that is so much tragic, but reality is so dramatic.
Content creators usually change back. Because they are, because in your age, they are Finish. Okay. Thank you very much. That is all. Actually, too many approaches that we do it. Okay. If there is a question, yeah.
So maybe I'll just start with a question, but then you're all welcome to join, and we hope you will. We have time. And also for people online, I hope they will have the opportunity to ask questions as well. So first, let me thank you very much for really what we have ourselves. Mary Jo and I've been now 28, almost 30 years working in Indonesia, and we've watched this change. And we watch it differently. And we watch it, so Pak Bambang, the driver, is completely happy. And then another person in our household, because she doesn't really trust it, she would rather pay. And she chooses to pay, even though she has BPJS.
Okay.
We know how these systems work, and it takes time for people to come to trust the system.
She asks us to pay.
And then she asks us to pay.
I think because you are very kind, so he or she knows this, and although it is covered by, they still ask you to pay.
So the one thing I wanted to ask, because I know you mentioned the issues of DRG, of diagnostically related groups. I wonder if you would talk about that and about how you structure the payment system. I think DRG's have been shown to work very well in some areas and less well in other areas. And I just wonder, what your experience is with that as a form of payment.
Right. I think the DRG system is good in terms for controlling the cost. But of course, for the quality or at least the satisfaction level, is not as high as the fee-for-service payment. Because fee-for-service payment, the doctors are very happy. They got more money. But just to see in the national level, before in Indonesia, the doctors, especially specialists who are very famous, they can set and can, propose price by themselves. But now no more. Now BPJS and the Ministry of Health discussed and how high. Actually, by law, it is the negotiation between Association of Hospitals or health facilities and BPJS, who should negotiate and then determine the price. And for DRG, of course, the problem is that for the doctors or hospital, actually, if they have ability to choose, they will choose fee-for-service rather than DRG. But for the nation, that because resources always limited, resources always scarce, so we have to have strategic purchasing. So DRG is a good thing to control the cost. We know how much is the cost. So should not too over, but should not less. So should be enough, but not too more. So like that. This is the problem. Then the problem is the hospital who actually usually they can care, they can treat, but some oknum, not many hospital, but there is hospital or doctors say that, okay, now change BPJS, just cover like this. Or if you use BPJS medicine, it is not effective. If you want to be effective, you have to pay by yourself, something like that. But the good thing is that total out of pocket is reducing into 25%, previously 50%. So that is of course, then we made average using many hospitals. Then the average for this diagnosis is how much? But that time, the problem sometimes in those who are determine the tariff depend also our influence by their profession. For example, if their profession is eye disease, eye expert, then the eye procedures, the tariff is higher rather than the other, sometimes like that. So of course, this is subjective also.
So we are beginning to have questions, I see, and I'd ask you to introduce yourself also as...
and help you.
Oh, okay, great.
Thank you, Prof. Byron. Hello, Prof. Gufran. I'm Marwa. I'm first year master student in the Global Health Delivery at HMS. Thank you very much for the presentation. And I realize how BPJS has worked so hard to make the national health insurance cover almost 100% of the population. I have two questions for Prof. Gufran. My first question is because Indonesia has a very large amount of informal workforce that you mentioned before that the payment from the people is already increased this years, but how the approach that the BPJS has been doing to make sure that the people is not only paying when they need, but they also pay when they are healthy.
They also pay
when they are healthy. When they are not using the BPJS, they are also paying the premium, for the informal sector especially. That's my first question. And my second question is, you mentioned before that the expenditure that in the Indonesia, more of it is in the hospital. We see before in your graph, what BPJS approach that will do to make it more efficient, especially because as far as I know, one of the approach is to increase the promotion and prevention in the primary health care. But beside that, what other approach to make the delivery of care is more effective? Thank you so much.
Okay, first is about informal sector. Of course, informal sector is not easy. If I'm the one who give the authority or make authority, then for me, just only 3 members. The poor, we have to pay. Then those who are working in the formal sector have the wages. We already done because employee pay 1%, employer pay 4%, and then informal sectors. But David already proposed also for the informal sectors, then we can have, subsidized depend on the ability to pay. So in the grade, not you are paid by government, but how much money you have. If you have like this, okay, we can help like this. That is for informal sector. If we can divide it into these 3, then everything is finished. So we can cut 100%. But the problem of the informal sector, sometimes they have money, sometimes have no money, but they are not the poor. That is in health insurance usually called as missing the middle. Yeah, we are having challenge on that. And then number 2, about the promotion prevention, how to goes down the budget, not all to the hospitals, but go to the primary healthcare. Of course, not only we are now increasing the benefit package and the way to pay to the primary healthcare. In the first history of BPJS Kesehatan, we increase the payment, and the payment is based on the capitation based on performance. And not only that, but we use the risk-based capitation. Not only that, but we also develop the digitalization that people from home, from any type, they can consultation to make healthier. And then, of course, we work together with the Ministry of Health, that screening should be increased. And also we are trying to increase the tariff or capitation in primary healthcare. But still, the cost is still in the hospitals. But we hope that in the future, now we, together with Ministry of Health, to make more develop of primary healthcare, not only, the medical equipment, but the human resources in health. So we put that. Okay.
Thank you.
You're welcome.
Hi, Prof. My name is Melinda. I'm the first year in the public health school. I'm actually a BPJS user back home. So I was just wondering about you saying that there's no discrimination right now.
Yeah.
I used to use BPJS for my healthcare, and there's like two different lines. One is for BPJS user and one for the other. So can you tell me more on how BPJS has decreasing the discrimination in hospital between probably like insurance user? That's my first question. And the second question is, what do you see on the several population in Indonesia that has like double insurance, like private and public?
Yeah.
Because I guess right now we all somehow need to have the public insurance. It's kind of like mandated for everybody to have it. And so what do you see for those who have both like public and private insurance?
Okay, for the number 2 question first. It is good to have 2 insurance. When you are like to choose your doctor, because in BPJS it is difficult to choose the doctor. So if you have private insurance, it is better. So you can have, and you can sometimes in the private insurance, you can go directly to the hospital without primary care. But now we are developing what we call it coordination of benefit. Coordination of benefit, we coordinate with the private health insurance. So those who have 2 insurance, they can maximize the utilization. If for the simple things, they can use private one. But when it is complicated, like heart disease, operation, usually many commercial health insurance not covered, or they have limitation. But BPJS no limitation. Everything is covered. No waiting time, or at least 2 weeks if never been done, or there is no, medical examination before. If you are at least and you can come to BPJS Kesehatan, BPJS Kesehatan will welcome you. Actually, I also would like to ask you for your experience. So how is your experience using as the, BPJS beneficiaries? And can you find cheaper premium than BPJS Kesehatan?
Of course not. Well, so far, I guess my experience has been good. That's why I always recommend it to my younger friend as well. Because I think the private insurance is also...
But if you recommend it, so for me, I'm sometimes afraid if too many rich people using BPJS. Okay, but anyhow, I think it is good because her experience is very good.
Yeah.
Okay. Then number 1 question about the discrimination. Of course, because money talk. Those who has money more, they will tend to or prone to, pay attention on money. And not only doctors, any other profession, politician, and many, something like that. That is bad thing, but it is reality. So, to reduce that, there are many things. First, that we have what we call it service promise. So that the hospital have to have commitment to provide commitment on high quality of services without discrimination. And they have to put that in the strategic place where the patient easily can read that there is no discrimination. That is one thing. Second, we have, as we mentioned about the kesan. So after receiving services, the patient can give rating, can give feedback whether the patient received discrimination or not, or other things. And not only that, if we get report many times that this hospital is always discriminate, then we remind them if they can do always like that, then we can cut. No more collaboration. So if no collaboration in Indonesia now, maybe the hospital will have very difficult to survive. Very difficult. Okay. But of course, there are still some discrimination, but reduce so much. Yeah. Any? Okay. Oh yeah.
Hi, Prof. Gufron. My name is Dwita. I'm from the Master of Global Health Delivery program here at Harvard Medical School. I have two questions actually. The first one is the spending in hospital is so much more than in primary healthcare.
Sure.
Do you think it's about the weak gatekeeping from the primary healthcare doctors? And if yes, do you have something like some idea how to improve that? And then the second question is, so I saw your presentation at the World Bank in 2021, I think. So it speaks about like the BPJS after its 6-year implementation, it has a deficit, which actually now it's becoming surplus because the contribution fee is increased. Furthermore, now we are implementing the INA CBGs, which I think is very clever. How do you think it will sustain? Do you think it's enough, or do you think there's room for improvement?
Of course, there is room for improvement. But as you know that there is no single country or health insurance in the world without any adjustment after several years. So the premium should be adjusted because the inflation rate and the cost is increasing, utilization is increasing. So someday it must be not enough. So therefore adjustment should be. But when and how, it is our homework. So the politician, for example, in Indonesia, we just finished election, and the judge just announced 2 days ago or yesterday that the winner is Prabowo and Gibran, the son of the current president, who will be the vice president. And we are planning to talk with the president that it should, in some terms, should increase and adjusted the premium, something like that. Okay?
Yeah. The other question is about the gatekeeping.
Yeah, I think you are right. Actually, the gatekeeper, our gatekeeping mechanism should work, but it works because we use some kind of indicators, and this relate to the payment. So therefore, we call it capitation-based performance. If you refer too many, then we can reduce the capitation. But the problem is, it is not yet optimum. Why? Many factors. One of the factors is that in BPJS, we say that if you refer to non-specialists, or we think that you are able to do it around 144 competencies, then should not be referred to the hospital. But the problem is Faculty of Medicine in various corners of Indonesia now not yet able to equip medical students that they have to be able to mastering 144 competencies. That is another problem. But of course, if no one who experienced in the medical school, they will not see this. But for me, I saw this. Yeah, because not all can equip the competencies.
I also want to encourage people who are watching online to ask questions. And I understand there is one question that's in the 2 questions that are in the chat section.
Yeah, please.
So I'm going to allow the question here.
Yeah. Please just open mic. Yeah.
Thank you,
It's clear enough.
Thank you, Dr. Gufron, for the great presentation. My name is Archita. I'm from Clinical Investigation and Harvard Medical School. I have 2 burning questions, actually. The first one is, how BPJS deal with referral limitation policy when maybe there's a disease that cannot be tackled by the primary care? And the second one, how BPJS keep up with research advancement? Because, for example, if colorectal screening have proven to be beneficial, so how long does it take for BPJS to approve to be accessible? Because we know that BPJS will provide query so people can have more great prevention. So how do you tackle that? Thank you so much.
Okay, Arsita. First of all, I would like to thank for your questions. That actually BPJS Kesehatan went from primary care referred to the hospitals. Of course, if it should be referred, then and it is not referred by primary health care, then the people or the beneficiaries can call us. There are many online and they can care center, for example, 165. Yeah, they can complain it. And not only that, and many, for example, can WhatsApp in 08111 I forget 65, something like that. So many things that they can do it. And they said, but if they are not doctor, the patient should not pretend as the doctor that, okay, I should be referred and they need to be referred, but why I'm not be referred, something like that. So this depend on the doctors. If the doctor in primary care see that it is necessary to be referred, it should be referred. But if not, then should not, something like that. So the gatekeeper function. Does that answer your question?
Yes, thank you.
Okay, you're welcome.
And the second question, how do BPJS keep with the advancement of research? As you said, you have a HTA, Health Technology Assessment. So how long does it take for example, colorectal screening is important, and how does BPJS deal with this screening? If it's seen as important, how long does it take to be approved to be in Fornas, Dr. Gufron?
Yeah. Okay. I think for Arsita, this is very tough questions. And of course, I think it depends on, because too many competing topics should be researched by HTA, Health Technology Assessment. So actually, Health Technology Assessment is under Ministry of Health, not under BPJS. And BPJS is not under the Ministry of Health. But anyhow, if it is very important and it is priority, for example, now the acupuncture. So acupuncture is very important because many doctors are learning acupuncture, but whether acupuncture should be paid by BPJS or not yet. So Health Technology Assessment, and it is not the priority of Minister of Health. So therefore BPJS now allocate the money to give to the HTA team to conduct acupuncture health technology assessment, something like that. Okay. So basically, actually, in the Ministry of Health, who choose which topic is the priority topics, like that. Okay. But if you ask me, and then we see that this topic is very urgent and important, then maybe we can allocate the money, especially Pak Mahlil, who is responsible for that. Okay, thank you, Arsita.
Thank you so much. Thank you.
Oh, I thought you would like to hand it, but you yourself, let's ask.
There is one question. Okay. There's one question online, Pak.
Oh yeah, see, please.
Okay, this is from Elizabeth Osborne, and she wants to ask: could you describe the situation of elderly people and BPJS Kesehatan, and also its enrollment, utilization services, and also the LTC benefits? And the second question is that is there any national strategy to address the needs of the lansia?
Of course, that as I mentioned, now we have epidemiologic transition. More elderly people are coming, and the number is now more than 10% of the Indonesian population. And utilization is higher than the young productive age. And therefore, now we have risk-based capitation. So those who have more elderly people, then we pay more money to the primary health care doctors. And of course, not only that, We provide the screening, we provide, consultation for the healthy elderly, and so on and so forth. Okay.
Okay. Let's see. We have the whole group up here. Everyone will get their chance. Don't worry.
Thank you, Prof. My question is, and I'm actually not a student. I'm working here in Boston, actually in the health payment industry.
Oh.
So it's very US-centric, much different than the public system that you have in BPJS. So my question is, as you mentioned, there's increasing spending on healthcare, and you have plans to reduce costs for the long term. My question is, how do you plan to keep people invested and spending on healthcare 10, 20 years from now, when people like us still young and eventually retiring? How do you, if you have any plans, discussions to make sure we can continue to contribute and enjoy BPJS? And my second question is, since I work in the US industry, we have, for example, specific health plans in the US, such as the health savings plan, which is a government account that allows you to put money in there and allows it for you to invest their money, but you can only spend that money for healthcare purposes. So like a 401k, but for the health spending. So my question is, do you have any plans or discussions about privatizing some of the enrollee side of BPJS to make sure people can pay for healthcare spending down the line in the future?
Yeah. Okay. First of all, I would like to thank for your very genuine and interesting questions. As you know that many bankers, economists do not realize that investing in health is more important rather than investing in other things. And they know it after they, old or elderly, they can, whatever the cost is, they will pay it. So although they already late, so as you have mentioned that I think US is very smart in terms of building in the 1965 Medicare for the elderly. So when they're young, they have to invest, but they will, use it when they're elderly. So I think people do not know that some said that actually investing in health again is more important rather than investing in other sector, including bank, including property. And it is many people are not realize this. So we have advocate this. And the good thing for us now, my minister is the banker. So he just realized and talked to many bankers that, okay, you invest in the bank is good, but not as important as investing in health. So therefore, health is not everything, but without health, everything is nothing. So therefore, we have to keep healthy, keep investing in health. Okay, that is, And number two?
So my number two question would be, do you have any plans to like?
Okay, sure. So now we are calling to the private insurance if they would like to, open and invest and of course, sell the commercial product. Insurance can work together with us. So public-private partnership is important. I think that's all.
Yeah. Hello. That's is on. Okay. Hello, Prof. Gufron. My name is Tika. I'm from master student here in HMS. I've been working in rural Indonesia for like couple of 5 years in Borneo and also in Papua. And then I was intrigued with your map showing about the coverage of 96% of the total populations. And I was working actually in West Borneo, which is still in the red color when you had the map. One of the problem that we had at that time is because of the patients that get the recipient's assistance or like PBI that cannot afford for individual payments. So they have like the opportunity to get the money, to get funded by the state budget or from the local government budget. My questions is, how can BPJS make sure that, I just checked the data that is not maybe right or wrong, but it's like around 36% of BPJS users are actually in PBI system, and how is actually kind of effort from the BPJS to maintain about the payment for these rural patients so that can be able to access the healthcare continuously.
Yeah.
Because the case that I had, sometimes like the local government budget, they just cut the budget without telling the patients that they need to move from the local government's budget into state budget, which is kind of confusing. And related to the first questions, when I was in Papua, like one of the problem there, especially in rural Papua, like in Asmat or like in Timika and in Gunungan Jaya, the first problem that they had, they don't have KTP or like the social ID number, which is actually very disheartening kind of. Right. What can I do as a doctor at that moment to make sure that the people here at least get the KTP? Because that's the first like the get entry to get the access of BPJS. So the questions is, what can BPJS do for the patients in very rural area that maybe still have a problem or like a struggling problem with the documentations? Thank you.
Right. I think that is reality and that is very good questions. But again, you have to know the task and responsibility of BPJS Kesehatan. When you are talking about the national identity number and he has not yet having, kartu penduduk, the national identity number, of course, it is not the responsibility of BPJS. You maybe can help them by working together with the, chairman of the region or the district, or maybe you can contact the home affairs, or you can contact to the social, social affairs, social affairs ministries or social affairs in the district. So they who dealing with the national identity number. If they don't have it, then it is problems, of course. But I think not many people are not having national identity number. But of course, you can still find 1 or 2%. So please encourage them, or maybe you contact the social affairs officials in the district level. And of course, now we are advocate together with Pak David. We are developing what we call it PESIAR. PESIAR meaning petakan. So we make mapping, tracing, and then advocating, then registering. So we will check one by one in village level. Of course, not all Indonesians are working well, but we are doing that. And not only that, for those who are informal sectors, as I mentioned, actually, we have to work together with the Ministry of Social Affairs, that they should be included for the national subsidized premium. If not, then the local government have to be able and to know it. But the problem sometimes, local government are not so aware, and social affairs in the local government also not quite aware of this. So then the civil society have to advocate and so to help them. I think that is.
Yeah, and I just want to appreciate, because I was also running a clinics in a very rural area, and I'm very happy with the raising of the capitation, which is
thank you.
It means a lot, especially for the NGO clinic who really help the people in communities area who doesn't really get the money, and we don't have any additional resources other than the BPJS capitations and the grants. So I'm really appreciated for.
And now we would like to, if possible, if we have enough resources, we will increase again.
Yes.
Yes.
Finger crossed. Yes.
Not yet, because we have limited resources. Even you cannot find, premium cheaper than BPJS Kesehatan. Okay.
Thank you so much, Prof.
You're welcome.
Thank you very much for the wonderful talk of Prof. Gufron.
Thank you, Sandy.
I'm Sandy. I'm a visiting research fellow specializing in public health and in mental health. So I have two questions. The first question I have comes from the fact that BPJS is a very rare system in which it has almost complete universal health coverage, but also very comprehensive data. I would like to ask, are there plans in the future to realize BPJS potential as perhaps one of the most accurate forecasting systems, health systems in the world, whether on the individual or population level? Could you comment a little bit about the work, the research, and whether AI is being incorporated to develop this?
Yeah. Okay, first for the AI, because AI is based on the big data. And BPJS Kesehatan have huge data. Every day, more than 1.6 million transaction data, and we capture all this. So therefore, many people, when they see the comment center in BPJS, they just, whoa, they're surprised. Because really, we can capture the data. So therefore, we give around the time, around 48 million data in public that many postgraduate students be able to access and to analyze. And now we increase the number into maybe more than 90 or 92 million data. So in the claim, for example, we use artificial intelligence that this automatically can capture that this hospital actually committed to fraud or not, something like that. So of course, even now, actually, we already developed whether someone already took or administered medicine or not yet. We have, but not yet implemented, but we already finished to develop that system because we have to wait for the Ministry of Health. Sometimes, for example, a question from the previous in the Papua or in NTT, because there is the floating hospitals, use the ship, and the floating hospitals, we wrote letter to Minister of Health, so how much we have to pay because this floating hospital classified as class A, class B, or class C, because we have to pay based on the class. But there is almost never answers, and already years. So therefore, we make our regulation. So this hospital should be classified, floating hospital, as the type C hospital. So we pay. So now many whose name? There are many floating hospitals go to the islands and something like that. Of course, we have to differentiate. Yes, we paid before for the the mission from the church, from many civil societies. They're doing without claiming because no one will pay. The judge collecting the money and then they go, but now they can claim to BPJS, so they are very happy.
This is a difficult question.
Sure, but it is not examination, because I'm not taking PhD.
Right.
Okay. Thank you, Prof. Marijit.
Wonderful talk, and I'm so excited about what you've been able to accomplish with your colleagues and leading the way to build the system. We've heard about the earlier versions. I have a difficult question.
Yeah.
How do you deal with, let's see, economic fraud?
Yeah.
Payback, so in Aceh, it was known that if the hospital was buying a certain amount of equipment that they had gotten funding from, say, IOM or the World Bank or something like that, that they would also, that purchase would also cover a gift to the person who was the senior in hospital administrator or these doctors who had many.
Yes. Yes, I know it.
Yeah, you know those.
Yeah.
I'm afraid to say it.
No, I understood. Yeah. Okay.
And then the second question is, how are physicians at the various levels reacting to this digital foundation?
Right. So number 2 question.
That's the second question.
Yeah, the second question.
Digital
transformation.
How are the physicians reacting
Okay.
to what's going on?
Okay.
The individual doctors,
Yes.
you know, are
Yes.
they upset that they don't have control?
Okay.
Or are they thrilled that they're getting paid?
Yes. Okay, I will answer number 2 question first. So your question is, of course, very interesting and genuine, although it is not examination. So actually, the response of the doctor, physician, they are very happy, mostly. Mostly they are very happy because I myself check to the hospital whether you are using iCare JKN or not. And they're using because they know exactly this patient, actually nationally, actually what type of diagnosis, what type of medicine, what type of visiting health facilities, what type of allergic things like that. So it really helped them. So they are very happy because they know before, asking another examination, they really know the condition of the patient. That is what I found in the field. Of course, there is someone who do not like it because they are, I cannot say also because they are, they have the business on, developing application and things like that. Okay. And then number 1, about the, price increase because of something in the hospitals. Just to let you know that actually BPJS Kesehatan is not dealing with the supply side. So we are dealing with the demand side. So supply side, as you mentioned about, infrastructures, about buying certain medical equipment, about placing specialists. Again, it is not our business. It is business of the Minister of Health or local government. I know it and how to deal with it, but it is not my authority.
Oh, you're so clever.
Yeah.
Yeah.
Actually, I would like to answer, but it is not my authority to answer it. So you should ask to address to the responsible person for that. Okay.
Thank you.
Yeah. So I just would like to talk the demand side. Demand side, there are 2 things: personal health and public health. I'm a public health person, but public health, for example, like, epidemic, surveillance, or maybe pandemic, it is again not responsibility of BPJS Kesehatan because it's public health. BPJS Kesehatan is responsible for increasing access, make sure the quality for the personal health, like cancer patient, psychiatric patient, and many things like that. Okay, so I actually know the answer, but again, it is not my responsibility to answer that, not my authority. So I have to not to answer to internet. Okay.
I'm going to ask one more question, and then I know we have at least 1 or 2 more, and I don't know whether we have other people online. We do. Okay. So this is a kind of obvious question in a way, but I watched when BPJS began almost a doubling and tripling of number of patients coming to Puskesmas.
Sure.
Suddenly, a huge rise because you require entry into the system through there. Often, suddenly, a system that was designed in particular to deal with either women and children, etc., or to deal with prevention or with emergencies, suddenly had patients coming in to be worked up for tumors. Should this person be referred, etc., and often with like 5 minutes to do so. And so I saw, at least at the beginning. I wonder how it's evolving now. The Puskesmas had a great deal of difficulty, I think, initially dealing with the sudden increase in patients and the sudden increase in numbers of duties that they had to take on. Are you working with the system to try to solve this?
Yes. Okay, first, I think that is, of course, our challenge. But again, when you are talking about the supply side, the infrastructure, number of doctors, specialists, that is not my responsibility. Although we support it. For example, now, the Minister of Health borrowed the money from the World Bank, 1.5 billion US dollar, and then from other sources, total is 3.8 billion US dollar. For what? To increasing the capacity of primary healthcare. And not only that, so they buy, for example, ultrasonography, and also for the education, to make sure that the health facilities in primary healthcare will be expand, will be, the capacity building will be there. Yes, it takes time, but you're right that the doctors, of course, now is too many patients, but I think gradually we have to dealing with that.
Great. I'm going to pass this along.
In online? Oh, okay.
So then we'll come back to
yes.
Online.
Hi, so I'm a visiting student from England. I just finished my medical degree, but I'm just here for an elective. Oh, can you hear? Oh, stand up.
Speak louder.
Oh, sorry. Did you guys hear what I said earlier?
Yeah.
Okay, so yeah, I'm a visiting student, and so in England you have about almost like 100% coverage for patients. But from my experience, what I've seen is that in reality, only 20 to 30% of people can access it, just because the referral criteria are so high, and it's supposedly very difficult to sort of fund everything. And I feel like a lot of it is because of bureaucracy. So how do you sort of, in your system, how do you manage to ensure that there isn't any element of like corruption or any sort of disagreements within institutions?
Yeah. I think first about the NHS, the waiting period for the elective surgery is around 4 months to 6 months, maybe more sometimes. 5 years. I make it. But in Indonesia, the waiting period for surgery,
4 weeks.
approximately less than a month. If they more than a month, they will sort it. They will report to the president or to medsos. They will create the many noise social media. So therefore, in Indonesia, for waiting time, for the elective surgery is very fast, less than a month. Of course, in some cases, for example, like heart surgery, sometimes more, but in approximately. So now, therefore, Minister of Health, the bankers, invest the cath lab and many things like that. Okay, so in England, if you know, a year around 260 billion US dollar invest in health. In Indonesia, is less than 30 billion US dollar. So you are right that actually we have homework on that. But anyhow, we are trying to increase the cost. Just last year, we have to pay more than 3 billion US dollar. The additional, we have to pay 3 billion US dollar because what? Because utilization is increasing. As you mentioned, also the trust from the community increasing to the BPJS Kesehatan, because they are now happier, and also the doctors is happier, also not abdomen happy, but happier than before. So that is our job. So again, what is I answer your question or not yet?
Oh, yeah. I was just wondering, what what do you think makes the difference between, Indonesia's healthcare system and England? How is Indonesia, so efficient and so great at it?
Yeah, of course. In England, it's better for the infrastructure, better doctors, better. But satisfaction level in Indonesia is better. Many doctors in NHS, and just a month ago, many group of NHS came to our office to see it. Yeah, and Indonesia never, strike or protested from the doctors. And it is, according to Minister of Health, it is not good. Why relationship of BPJS and doctor is good? It should be not good. It's good, it means not good. He said like that. I said, no, we have other approaches, how to approach doctors and specialists. I'm a doctor by background, so I know how to be approached and to have a good relationship. Although now is the relationship between BPJS and the ministry is the best in the history of BPJS. So our relationship is good. Okay.
Thank you very much.
Hello, Prof. My name is Hasto. I'm currently a master's student at MIT studying economics and public policy. So my question is related to moral hazard. So I think many literatures that I read during the class related to health insurance problems is related to moral hazard. So my question is how the condition in BPJS Kesehatan about moral hazard and how we can anticipate in BPJS Kesehatan context, how we can anticipate moral hazard. I think that's my question.
Okay.
Thanks so much.
First, Hasto is not Hasto Kristianto.
No.
Hasto Kristianto is the Secretary General of PDI Perjuangan, the struggling party. And I'm afraid if he is still struggling here. Okay. That how to deal with the moral hazard. Of course, every day we are dealing with the, committed the, fraud and moral hazard, thing like that. And we know actually, now we are proposing, and I said to the Ministry of Health, okay, because Ministry of Health reported to the President that in the IKN is the new candidate of the, Ibu Kota as the capital of the Indonesia. He said that now already 5 new hospitals started building in IKN. But there is not yet population over there, but already 5. So I said to the Minister of Health, we have to be careful in the business and health sector. Because in health sector, okay, if we have medical equipment, for the investor, non-medical person, they will say how many a day should be CT scan or should be covered to be able to get the break-even point of the investment. But the doctors should have ethical things, should not unnecessary utilization. They should know that this person actually are not necessary to be scanned, something like that. So this, we have to talk with the investors. So therefore now what we are doing, we have mapping. So we already have mapped out and we call it, peta kita. JIS, using JIS. But we know which area still needed to be investment of the hospital or new clinic. So should not only based on the, business-oriented consideration. Because if they only do that, so they will buy CT scan, buy cath lab, and build a hospital in the, commercial complex only, something like that. Now we, discuss with our supervisory board that actually the investor, before they investing and building the new hospitals, they should consult to BPJS in which area we should invest. And we already, for me, I talked to the Ministry of Health. So Minister of Health, in the near future, we will say to the public if you build the hospital in this area, so the next 2 years we will not collaboration, something like that. In Indonesia, if BPJS not collaborate, it's very difficult to survive. They can survive, but difficult, something like that. Okay. Yeah.
So I think at this point we should certainly go back to the online questions. Are there no more?
Okay.
Sudah? Okay. We have Celine will answer, and then I think we'll bring this to a close.
Hi, hi, Prof. Ali Gufron. My name is Aline. I'm a physician from Indonesia, Universitas Erlangga, and I'm here in my final year in the Master in Global Health Delivery program as well. And my interest is actually in health financing, so I'm very interested in this section, but apologies for arriving late because I came from class. But my question, just two very quick questions. The first one is we learn in health systems that and from my experience practicing in Indonesia, there are a lot of, in the primary care level, we have lots of puskesmas, we have clinics, Vaskes tingkat pertama, we have individual physicians. So I'm curious how BPJS has, what methods do you use to monitor the qualities of your primary care providers? And the second question is, has BPJS done any shift towards a performance-based financing or value-based purchasing recently? Because I haven't been to Indonesia in like a few years, so I don't know the newest news.
So you usually call?
Celine.
Celine. Okay, Celine. First of all, actually I will already explain, but I can repeat again.
Okay.
So in Indonesia, we call it capitation performance-based. Yeah, so capitation based performance. So if the primary healthcare doctors or clinic perform better or well, then we will pay higher capitation. How to measure that? At least now, three things. First, the contact rate. How many contact you with your patient? This is number one. Number two, when you refer, whether actually you refer more than 15%, especially to, specialists, to non-specialists, which is we consider that you should be able to take care of the patient, but you refer. This number two. And of course, number three is related to consultation also. Now we would like to add some more performance. So we perform, and also in the primary care, we have commitment of quality of care. So you should sign and should give, announcement to your clinic or to your, primary care that you will not, you will serve with satisfaction level, with more comfortable, non-discrimination, and you will not ask for photocopy, for example. No need photocopy. And of course that you will receive with national identity number only. So if person without member, BPJS card member, only using KTP, you should and have to receive that. Otherwise we will show you and we will remind you that you are, you should increase your quality, something like that. And we know, as we mentioned, using the command center, 23,000 more FKTP or clinics or private one, mostly are private because 64% of private. We can monitor whether you are actually good doctor or not good doctor. Yeah, that is amazing because we know, each doctor every day how many contact rate, how many you referred. Not only that, in the hospital, each doctor, when your permission will finish, you should update new one, and then how many surgery you are conducted a day and things like that. So we know it. Unfortunately, many doctors do not know that we know them. Therefore, we created a song also that you don't know, something like that. And you can see in the YouTube, so you don't know.
So when they go back to Indonesia, you can track their performance.
Sure. And you can ask your performance. You can ask us, and we will give you. That is your performance. Sure. How many you refer? How many you are contact rate? Yeah? And many things we can give you.
So I think with that, we're going to bring this to a close. And I first want to thank Prof. Gufran for coming and giving this talk and for his generous time with us. I know he's also worked with some of our students here and over the years, and I know that he's been generous with his time in many, many ways. He's been generous with his time with Mary Jo and me over the years. And so it's been a great pleasure. And secondly, I want to congratulate you and your larger team for what you've achieved.
Thank you.
I think it is really quite remarkable, and clearly you've brought along Prof. David and Mahlil,
Yes.
and Boo Dindin. And so it's thank you for all of your hard work and also for coming to visit us at Harvard. You were, I know, in Washington and made this trip here, and we're very, very pleased. And so I just want to thank you all and have a round of applause.
Thank you very much.
Thank you very much. So with that, I think we'll end the